very, very much, Bridge. It's a pleasure for inviting us to come up today. It's really a pleasure to be here. And I'm going to be speaking a little bit about atrial fibrillation and giving sort of some updates in terms of particular more invasive techniques to treat atrial fib. Can everybody hear me? Okay. So with regards to atrial fib, I think most of us as practitioners probably feel somewhat like this. And I put this up as an illustration because atrial fib has become such a kind of overwhelming topic and an overwhelming disease state that we treat in so many cardiovascular patients. And this is how I sometimes feel, sort of like Sisyphus on the left there, or the David and Goliath, because it's a really a disorder that sort of keeps on giving in the sense that you think that you can treat, and patients recur, patients have symptoms, patients have a lot of morbidity. And I think if anybody picks up any random journals in cardiology, regularly are multiple headlines with regards to the treatment of atrial fibrillation, and especially with regards to catheter ablation, because this has been really an evolution in terms of the way we treat patients. And we've sort of learned a lot over the years, and I'm going to illustrate some of the newer things that are going on today. So with regards to the disease state itself, I'll go a little bit over the mechanisms and background, or what's understood about mechanisms, and that's really the tip of the iceberg. And then we'll talk a little bit about patient selection, treatment modalities, outcomes, and then some of the future directions. So I think everybody here recognizes that atrial fib is really a fairly complex disorder. And there have been multiple theories that have been put forward in terms of the origination of these being sort of focal drivers in the atria that give rise to atrial fib, so the recognition that the pulmonary veins play a very big role in the disease state. But then in patients that are older with more comorbidities, the idea that there are multiple wavelets, multiple reentrant circuits that can occur. And this is very simplified in this diagram. And I'll go over some of the more recent sort of knowledge of the disease state itself. But we all know from demographics that this is a huge problem in the United States. It's estimated that the population at large is probably somewhere in the order of 3 million, estimated to double in the next few decades. So this is a problem we deal with every day. But with regards to treatment modalities, I mean, what really has launched forward in the last sort of decade has been the idea that these are really related to two predominant mechanisms, which is reentrant states, so reentrant circuits within the atrium, or this single focus idea. And because of this reentry, the idea came from the surgical literature, which was to try to do a procedure to compartmentalize the left atrial and the right atrium, but mostly the left atrial area that's available for this reentry. And then the single focus sort of phenomenon, the idea that there's one triggered spot in the atrium that gives rise to atrial fib, that if you could target that focal source and ablate it, or sort of get rid of it with cautery, that perhaps you could do some good. And the reason really for the development of catheter-based techniques to treat the rhythm is really illustrated in this graph, which is the idea that drug therapy is really not very good. I mean, if you look at, this is really quite old data now from the AFFIRM study, but looking at the types of drugs that we still use to this day, class 1 drugs, sotalol, and amiodarone, really at beyond 1, 2, 3 years, the efficacy of these drugs in maintaining sinus rhythm is quite poor. We use them because we need to use them, and there are many patients that can't undergo invasive techniques, but just to say that this is what's really launched the idea that we have to do better in terms of treating these patients. So the limitations of drug and device therapy for the treatment of AFib, the realization that these focal mechanisms play a role, and then really the resurgence of transeptal catheterization, the techniques and technology that led to the ability to easily cross the atrial septum to be able to get at these areas in a very minimally invasive way has really revolutionized the way we treat these patients. Advances in imaging, and I'll go through some of that, and some of the advances that we do in the electrophysiology laboratory. So with regards to the guidelines, these are the most recent atrial fib guidelines that were published in circulation in this year. And you see that catheter ablation now has really risen in terms of in the ranks of treatment modalities. That this should really strongly be considered for patients that are, especially those that are drug refractory, and continue to be symptomatic and don't have other significant comorbidities. And we'll go over some of that. But even in patients with structural heart disease, in those patients that have coronary disease, that have heart failure, those patients we are treating today. So just a word about patient selection. The way we sort of approach these patients, that patients really fall into a few different categories, which is those that are paroxysmal, so patients that really have recurrent episodes, but they're short-lived. They terminate either spontaneously, sometimes with taking a maintenance drug, but they're not things that require cardioversion or require any immediate intervention. And those patients that are more persistent, so sustained episodes lasting greater than 7 days, or even less than 7 days, but those that require pharmacologic or electrical cardioversion. And then those patients that are really long-standing persistent. We do take care of a lot of these patients with other forms of heart disease, and those patients in which a decision has been made really that they will stay in the rhythm and they'll be treated with a rate control strategy. So when you read the literature, these are the patients that sort of are divided up because the outcomes of catheter ablation for these patients vary highly dependent on the patient population you select. So paroxysmal patients really are the patients that have been shown by and large to benefit the most from catheter ablation. And those are the patients that we really, really want to get at earlier in the disease process. So patients that have symptomatic AF, refractory or intolerant to antiarrhythmic drug therapy. And now there's even increasing literature to suggest that as a first-line therapy, that patients that, especially that are relatively young, without significant comorbidities, that the idea that you could take these patients for catheter ablation up front may help them. And we'll talk about some of the trials that have demonstrated that. And then the idea of persistent and permanent AF, that catheter ablation may be beneficial in these patients, but that on a selected basis, because these patients often have significant other comorbidities. Obviously, if there's significant structural heart disease, significant heart failure, the outcomes of ablation are going to be less, but we do use the modality in some patients because of the refractoriness of symptoms. Very difficult to control heart failure, very difficult to control with medication. This is put up really just as reference, and you can refer to it, but the latest published guidelines with regards to catheter ablation, and that it really is a class 1 indication for patients that are intolerant to drugs and refractory. I get a lot of questions about anticoagulation and whether catheter ablation is an alternative to being able to use anticoagulation, and do we base our decision to ablate on the need for anticoagulation? The answer, in short, is that the decisions we make with regards to anticoagulation, because stroke is so potentially devastating, we really make those decisions based on their underlying comorbidities and not because we believe that just by doing the ablation that their stroke risk goes away. So most patients, the great majority of patients that undergo any kind of catheter ablation have to be able to be anticoagulated for a minimum of 2 to 3 months post-procedure, and that the decision to discontinue the anticoagulation is really made based on what their pre-existing risk was before going into the procedure. So those that are of high CHADS2 or CHADS-VASC risk, we tend to continue their anticoagulation. So the short answer for this is really, we don't use it as an alternative, just to say that as purely the desire to eliminate the need for warfarin or other novel anticoagulants, it's not the indication for AFib ablation, but that we do it in conjunction as a treatment modality, and we usually keep patients anticoagulated if their stroke risk is high. Just a word on some of the newer techniques with regards to ablation. So I'll go over kind of why we've developed the techniques and the idea behind it. We've talked a little bit about the idea that paroxysmal AF is a trigger-dependent phenomenon. And that's why there has risen the idea that we can isolate areas that give rise to these triggers. In persistent AF, it's really a little bit more complex and a diffuse disease, and I'll show you some pictures of that. And so because of that, in any given patient, we really do sort of tailor the ablation scheme to the patient that we're treating. And that's based on many factors, based on imaging that we do pre-procedurally, based on what we find when we map inside the heart at the time. But I'll go over some of the mainstays of what we do. And this rationale has risen from the role of the pulmonary vein, okay, because the pulmonary vein sleeves that insert into the left atrium tend to be some of the richest sources of focal drivers of AF. And the idea that you could isolate those pulmonary veins and have a significant benefit is really what's launched the entire field of catheter ablation in AF. But the role of muscle and scar also plays a huge role. So those patients that have more persistent or even permanent AF tend to have a lot more substrate involvement. I'll show you some pictures of what that means. So the two predominant techniques for catheter ablation really center on what's called pulmonary vein isolation and or left atrial linear ablation. And then combinations of the above techniques are now being used with newer technologies, and I'll go over some of that data. And then lastly, I'll touch a little bit upon surgical maze and minimally invasive thoracoscopic surgical maze, which is now being done at our center. So this is just a schematic to show what we mean by pulmonary vein isolation. We're basically electrically trying to isolate by either burning or now freezing the circumferentially around the pulmonary vein antrum where they insert into the left atrial body. And so this is taken from an actual case in which this was a series of point-by-point radiofrequency burns around the pulmonary veins. But the strategy really is to isolate these veins. And that strategy has really evolved from the early days of trying to go after drivers within the vein itself. Instead of isolating the vein, why not just try to destroy or kill this one spot? But that led to the concept that there are usually multiple drivers, and that by ablating deep within these pulmonary veins, there could be some adverse events. There can be pulmonary vein stenosis over time. And we'll talk about that in terms of the safety issues. But this has really conceptually just gone from the ablation of a focus to electrical isolation of the vein. So you can imagine if things were very simple and a patient, all they had were these focal drivers, you get rid of the drivers, patient's cured. And it turns out that there are many paroxysmal patients where the drivers really exist in these focal areas, and they do very, very well post-catheter ablation, that they really generally are cured from the disease. But that's very different in a heart like this. So this is taken from one of our patients where we've actually mapped the electrical voltage within the left atrial body. So here's the pulmonary veins, and this map is really shown to represent purple areas being healthy, viable atrial tissue, and the areas of gray being completely scarred or no tissue, no viable sort of myocardium. And then the color scale in between showing that there's a lot of dense scar in this heart. So this is a patient that really, by ablating the pulmonary veins, it's unlikely, long term, that this patient is going to derive significant benefit. And so what has then evolved is the idea of doing left atrial linear ablation on top of pulmonary vein isolation. And this really comes, some of this work is really derived from the surgical work that was done with surgical maze, which is the idea that if I can compartmentalize the atrium, if I can box it up into different areas, that I can basically prevent some of these reentrant electrical random circuits from propagating, and that long-term patients do better than with just drug therapy. And so this became known because pulmonary vein isolation was really insufficient to treat some of these patients. And the idea is that a lot of these patients now, once you've done this kind of compartmentalization, the rhythm, even if they recur with arrhythmias, that rhythm recurrence is often not atrial fibrillation. It's usually atrial flutter. And those atrial flutter circuits are actually readily ablated. They need repeat procedures, but just to say that the substrate overall can be changed by doing these kinds of procedures in these patients. And so this is just a schematic showing the same concept of ablating or isolating the pulmonary veins and then creating these linear lesions to further segment up the left atrial body. There's a lot that's evolved also about autonomics. I think if you read any of the literature these days, autonomics is a very big topic now. Autonomic input to the heart governing certain arrhythmia mechanisms. And it's well known to be associated with how atrial fibrillation starts, propagates, and ends. But it's also now well associated with ventricular arrhythmias and other things. So this has also led to a whole field of trying to determine whether, on top of doing the kinds of ablation we're doing, what if we targeted some of these autonomic inputs, some of these ganglionated plexi that reside on the epicardial surface of the heart? That if we basically could eliminate some of those, the patients would do better. So in addition to some of the ablation that's done today, especially on the surgical side, there's a lot of attention being paid to these ganglionated plexi. In terms of how we do these procedures, I'll mention a few of the techniques, but The mainstay is still radiofrequency ablation, which is using catheters. This is newer technology now where we have the ability to sense force. So we've gotten much better at being able to isolate or burn tissue without causing peripheral damage. And this is just the idea that you can measure the force of your catheter at the time you're creating these lesions, so that the idea is that you really create burns through the myocardium and not harming any adjacent tissue, which would be things around the heart. Another newer concept, and this is something that we use very frequently in our center, which is called cryoballoon ablation. So the idea that pulmonary vein isolation can be done a little bit simpler nowadays with less morbidity to the patient, with these balloon technologies that are essentially created to isolate the pulmonary vein in sort of one foul swoop, and to give you a much more uniform lesion rather than what I showed you before, which was these pinpoint lesions. So cryoballoon ablation really has evolved now to be kind of a mainstay of pulmonary vein isolation procedures. And some of the data for that has been shown time and time again. This was one of the biggest trials that was done to show the efficacy. Really the efficacy out to about a year to 2 years is quite good for these procedures in terms of ablating versus the use of just drugs alone. And in any of the randomized trials, and there have now been numerous randomized trials, which I'll show you, really for at least short-term outcomes, when we talk about years, so 1, 2, 3 years, patients are going to do far better, especially the paroxysmal patients, with catheter ablation versus drug therapy. That's not to say that we are necessarily completely curing these patients, but their morbidity goes way down, their symptom state is much improved with the use of these modalities. This is just to show some of the more recent data. This is now a newer technique, which is the idea that in these very complex substrates, which I've shown you, where the atria is very diseased, can there be better ways of mapping the heart and individualizing ablation for any given patient, so that there are focal rotors or areas that drive AF in the setting of these complex kind of scars. And this is just a newer technique that's now kind of evolved and being used in many centers to ablate, just showing that if you go after some of these focal rotors using these newer techniques, that the outcomes are still better than standard ablation therapies. I touched a little bit upon the recurrence of certain types of left atrial flutters. This is just to show also that many times now when patients recur with arrhythmia after these catheter ablation procedures, it's not necessarily atrial fib anymore. And a lot of them, what happens is that we create, by doing the ablation, we actually create these circuits in the heart and these atrial flutters. But with newer mapping techniques, these are techniques now that you can create a comprehensive electrical map of the heart. And this is a map that was created in just 10 minutes, where you collect thousands of electrical points and data and can quickly identify where the circuit is, that all it would take is a few pinpoint burns across this atrium to isolate this circuit, and the flutter goes away. And those patients really tend to do far better over time once the left atrial flutter is taken care of. In terms of surgical ablation, I think everybody in the room is familiar with the word maze or Cox maze, that this was really an adjunctive technique to treat atrial fibrillation in patients with valvular heart disease, patients that were undergoing surgical valve replacement or repair, or bypass surgery. And it was the same concept, which was to cut and then sew, or it evolved into either radiofrequency application or cryo application of creating these linear lesions around the atrium, the left atrial body, to the mitral valve annulus, creating lesions on the right atrial side, such that if you compartmentalize this atrium, that you could prevent propagation of any of these circuits. And so this led to the concept of, could this be done minimally invasively? Okay, so instead of an open concomitant procedure, let's say that we have a patient with this very hard to treat atrial fibrillation, but they don't need valve surgery, they don't need bypass surgery. And so this has led to the minimally invasive techniques of using thoracoscope. So these are done really with a few small incisions. I think Dr. Shah here works with the surgical team as well. We have Dr. Poinazad that does this technique now in a simplified manner, using a thoracoscope to basically isolate the pulmonary veins and create these lesion sets, all done epicardially. So all done from a few small incisions on each side of the chest, where they can really get a good transmural lesion. So you're basically able to approach things that are harder to approach from an endocardial position. And this is just a schematic showing sort of what this would look like from the outside, and they have these clamp techniques that they can actually get around the pulmonary veins and effectively isolate and burn. And the advantage of these maze procedures that are done thoracoscopically, there's no sternotomy, these are not done with cardiopulmonary bypass, there's no thoracotomy, these are small mini incisions that are made, and that you can really perform a full lesion set. We usually can go into the procedure at the same time, so this is done in conjunction with the electrophysiology team to confirm that all the electrical endpoints have been met. And at the same time, most of these patients undergo an exclusion of their left atrial appendage. So from the concept of stroke risk long-term, these patients really have their left atrial appendages isolated or disconnected from the rest of the atrial body. And so some of the outcomes with regards to thoracoscopic maze, this was almost up to date, but in terms of we've now launched this program about 2 to 3 years ago at Cedars-Sinai, and we've had pretty good outcomes. These are patients that have failed, usually 2 catheter ablations. These are usually persistent patients. These are usually patients with a fair amount of substrate abnormality or scar in the atrium. And the majority of these patients have actually done exceedingly well with pretty extensive post-procedural monitoring to show that the majority of them are in sinus rhythm, and of the recurrences, many are related to flutter, and those patients we've taken back and ablated their flutter. So I think that this has a role in the future. In terms of outcomes and safety, I think I'll touch a little bit just upon the data. Really, most of this has been usually multi-center studies, but many studies published over many journals now with regards to antiarrhythmic drug therapy versus catheter ablation. And the majority of studies have shown that these patients do quite well. This is a meta-analysis that was published in CERT a few years back, but just showing that, again, patients really overall with catheter ablation, either single procedure success or multi-procedure success is on order going to be significantly higher than that treated with antiarrhythmic drug therapy alone. And that's important because it's a useful treatment modality. Again, we've set the bar very high in cardiac electrophysiology, that we're very used to a certain rhythm being able to say, single procedure, we're going to treat this rhythm, and the rhythm is never going to come back. Atrial fibrillation is a complex disease, but we're making strides in better ways to treat this. And over the years now, more longer-term data has emerged because we've now done this procedure for a number of years to show that there is durability to some of these procedures, that especially in patients that have relatively paroxysmal or early persistent AF, that long-term they do very well. They're free of sinus rhythm, or they have minimal episodes of atrial fibrillation that can be easily treated concomitantly with the drug, rather than if they were treated with just drug alone. And this has been shown both in multi-center studies and single-center studies, that the paroxysmal patients especially, this is a single-center study from New York, but done over many years, over, I think, almost 1,000 patients in this study, where they showed that really there was durability out to many years post-procedure. So what about recurrence? I get a lot of questions about, well, okay, because a lot of the surgical literature suggested, well, if the patient doesn't feel anything, then they're doing great, right? The rhythm isn't back. So we've evolved now in terms of how aggressively we survey these patients. After procedures, we use a lot of post-procedure monitoring, longer term. I just show one modality, which is easy for patients, but some people are implanting small mini recorders to see the exact burden. But just to say that I think we're getting better and better at looking to make sure that there's no asymptomatic episodes, because we obviously don't want to miss those with regards to thromboembolic risk. So one thing is the way patients feel, the other thing is protecting them against other morbidities. A few words on safety. This has really evolved now to become a much safer procedure. So the older literature between 2002 and 2005 showed approximately a 6% complication rate. More recent data has suggested that the complication rates have fallen down into the 3% range. So these procedures are really done all with groin access. These are, transeptal techniques. And the risk, we've learned a lot in terms of doing these things safely to prevent issues like tamponade, stroke, and pulmonary vein stenosis. By ablating the way we ablate today, the rates of pulmonary vein stenosis have fallen. The risk of any other phrenic nerve injury or fistula is exceedingly small, and most of the complication rates center around either tamponade or vascular complications. But they are getting better in year after year. So just a word on future directions. What are we hoping to achieve in the future? So nobody really has significant multi-center worldwide data with regards to kind of the real world. So a lot of these patients that were studied were paroxysmal patients. They were probably early in the disease state. So what about the real world? So this is probably the largest trial that's underway to look at the concept of doing catheter ablation in patients, especially that are older, patients that have significant comorbidities, and randomizing them to drug therapy versus ablation. And this has a pretty high bar to set in terms of looking at total mortality. So can these procedures actually help with survival in these patients? And this is a study that's been hard in the modern day to actually complete because many patients are highly symptomatic and want ablation. They don't want to be randomized. But it is well underway, and I think it'll complete hopefully within the next year. And we'll look forward to some of that data. Another trial that we're involved in at Cedars, which is the concept, because we do believe that surgical techniques allow access to certain areas of the heart that we don't have from an endovascular perspective or from the technologies that we have today, is this Stage Deep trial, which is, we're going to be, our surgeon is the principal investigator for this trial, and basically we'll be looking at doing what are called hybrid procedures. So in patients, especially that have previously failed catheter ablation, that are highly symptomatic, the concept of doing both an endocardial and an epicardial approach for these patients, usually not in a single setting, but in a staged setting, to really help the long-standing persistent patients. So we look forward to participating in that trial, and we'll look forward to the outcomes. So in summary, I just want to say that if you look at the literature, and we as practicing cardiologists and electrophysiologists treat a lot of these patients, ablation really is a far more effective therapy than medical therapy alone. That's not to say that every patient needs an ablation. It's to say that consider it as an adjunctive tool in patients to treat, especially those with symptoms. And that techniques have evolved, they've provided new insights. We're continuing to learn day by day new insights into the mechanisms behind AF, that safety profiles have really improved, and that we do believe some of these percutaneous epicardial, endocardial approaches may have better outcomes long term. So that's all I have. Thank you very much.
Thank you, Mike. That was an excellent synopsis of atrial fibrillation. In my practice, I see roughly 10 patients of AFib every day. And it's wonderful to have the resource under our roof, Mike and X. Thank you very much for being there. Any questions? Now we have 5 minutes of questions for Mike. Yes, please.
I'd like to know how expensive to have procedural treatment, because I'm getting old. And I don't know how popular this disease will affect America. America spend almost $9,000 a year per person. This may cost too much money for majority people. I don't know how much money I have to save in order to make this problem. I'm not young anymore. I'd like to know how can I save the money. Number two, how can I prevent from this condition? See cardiologists and you too. Can you tell me how can help me prevent this condition? Not to see you. Thank you.
So those are both excellent questions. I think the cost issue is a huge issue. I mean, I think we're all acutely aware of the healthcare economy and the way things are going now. And I think that's why we need to do a better job. We need to do a better job with regards to two things, with regards to patient selection. So who goes for these procedures, who we really think is going to benefit the most. And number two, are there more effective ways to do these procedures so that patients don't require repeat procedures? And that's where the field is really going. We're trying to do a better job of understanding mechanisms so that we can tailor approaches to an individualized patient rather than saying everybody needs this kind of ablation. And that's been, over the years, this is an evolution. So I think that we're all acutely aware that we need to do a better job with regards to outcomes, but also a cost-efficient job. So I think you're asking a very good question. And the procedures are expensive. Most insurers do cover them at this point, but long-term, whether they'll continue to cover multiple procedures or for every patient is a good question.
You haven't answered my question yet. I wanted to teach you how to prevent this condition.
I was getting to your second question. So your second question was, how do we prevent this disorder? So the simple answer to that really is that this is an arrhythmia that keeps bad company. So the majority of patients we see with atrial fibrillation, actually isolated lone, what we used to call lone atrial fibrillation, is quite rare. The majority of patients with atrial fibrillation have some comorbidity, and that comorbidity is usually cardiovascular disease, coronary disease, diabetes, hypertension, and if those things aren't well controlled, then often these arrhythmias are harder to deal with and harder to treat. So I think that's a simple way of answering your question, but the same things you can do to prevent coronary disease, or to prevent progression of coronary disease, to prevent progression of comorbidities with regards to hypertension and diabetes, are all going to go a long way to treating this disorder, which I think everybody in the room is trying to do regularly.
That's a very comprehensive discussion about finances and how to deal with the dichotomy of care that's expensive and the money that we don't have. Moving on. And of course, alcohol and obstructive sleep apnea and stuff like that, which are correctable or potentially avoidable causes. Justin.
I have a question. One of the problems that came up with surgical maze was that the left atrium could go very flaccid and increase the risk of thromboemboli in the sinuses. They partially offset that by tying off the left atrial appendage. When you're doing a catheter method, you include the cryoballoon plus the left atrial linear plus the anticoagulation. You're starting to approach that. There's two surrogate markers people use, which is left atrial velocity dropping below 40 centimeters per second, and the atrial EF. Do you have any studies about how much damage you do to those mechanisms that protect you from thromboembolism and sinus disease?
Yeah, that's an excellent question. So it's well known from surgical data, and it's actually, there is catheter-based data in terms of this issue of the more ablating you do, perhaps that these patients, from an atrial structural perspective, don't do very well. That they develop either what's called atrial standstill, or that the atria becomes very stiff, this kind of stiff atrial syndrome. And that sort of alludes to what I talked about before, and that's why we really still treat patients' thromboembolic risk with regards to other comorbidities, rather than just saying they're in or out of atrial fibrillation. So in the old days, when surgical maze was done, if the patient followed up, they're in sinus rhythm, oftentimes those patients could be taken off anticoagulation. Their left atrial appendages were ligated at the time. We now have ways probably that are coming in the future to be able to occlude the left atrial appendage so it's out of the picture. But still, we believe that we base the anticoagulation strategy on their pre-existing risk. Is there good catheter data with regards to the long-term, this kind of stiffer atrial heart or other things? There isn't, to be honest. It needs to be better studied, because we're probably not doing as extensive of ablation with catheters with comprehensive maze. But it's a very important point. And we take the anticoagulation issue very seriously post-procedure for that reason.
Well, thank you, Mike. I know that the conversation